Today's episode of the Gestalt Education Show is brought to you by three of our favorite sponsors: Human Locomotion, Core 360 Belt, and Dynamic Disc Designs. All the information can be found below. By now, you have definitely heard us talk about them, so check out the show notes, click the links, use the codes, and make sure you support our favorite people. As always, we got a great episode lined up for you today, and thanks for tuning in. All right, everyone, welcome to another episode of the Gestalt Education Show. We're back in Troy with the one and only Dr. Erika Mennerick. And so if you missed the first episode with Erika, we talked a little bit about a heavy subject, and that was the subject of loss and dealing with loss. And so today we're going to bring it right back to manual therapy. And so I know Erika first because the first time I ever saw you teach was MPI, Pregnancy and Pediatrics course. And now I've grown to know that you're a little bit more than just pregnancy and pediatrics.
Thank you. I appreciate that.
Yeah, unfortunately, you get a little tight.
That's called typecast.
Yeah.
It's okay.
But we thought that this would be a perfect. We're here for the DNS Pediatrics 1 course and with Marcella, and it's amazing weekend. I'll get your thoughts in a second, Erika. But one of the biggest questions we get is about pediatric manipulation, and we see a ton of pediatric patients in this office too. And obviously, the more you know about DNS, the more you know about pediatrics, which kind of melds itself together a lot. And so, Erika, can you kind of talk us through, I guess, when you first started thinking about pediatric manipulation? I'm guessing school, but kind of like what drew you to, I don't know, understanding that a little bit more.
Yeah, it was my own mistakes of having children is what really led me to it. No, not mistakes. It's I'm really blessed to have two really awesome kids. But when I was in chiropractic school, that's when I had Cole. I was in 9th try, kind of freaked out, like, what the heck am I going to do with my life with this baby in my arms, and how am I going to start a practice? But it did absolutely force me how to figure out how to deal with kids. I mean, that's one way to do it. Right. So yeah, that was part of it, is just having my own kids and wanting to figure out and be able to do well for them. And took some of our coursework when I was back around Chicago. But really a lot of it has just been like building confidence in my hands-on skills over the years, and taking those motion palpation concepts and then applying them to pediatric patients. Yeah. So that was the biggest thing, was being thrown into the deep end. Quite
I love it. That's good.
I think too, like, since we're at a DNS weekend, like one really important thing, epiphany moment for me with treating pediatrics, was when I understood the connection between how the brain's using muscles and how that's tied into joint blockage. And I say that because a common question is, well, just because you got a kid in front of you, does that mean you need to adjust them if you're a chiropractor? And I think that that's a big misconception. And one thing we find, like we've heard Marcella over the weekend talk about, the pediatric patient and that 30% that's not developing the way that we want. And like understanding how that 30% is often the one that also has joint blockages. And I think that kind of highlights the connection that exists between when we're not using our muscles correctly and how that ties into joint blockage, how we can palpate it, and then how we adjust it. So Erika, what do you think are some of the differences that you've noticed, and I'll comment on this also when you're done, that you found between the difference on what joint blockage feels like in an 8-year-old or a 5-year-old versus what a joint blockage would feel like in a 50-year-old or 70-year-old?
Yeah, it definitely has some more spring to it in an infant and a younger kid, but it's still, like, as we talk about, like, you're always comparing joint level to joint level, and that same concept applies in infants. It's the same concept applies in younger kids. I think the other thing too, that when we're working with a newborn, is it may not be so much just a segmental joint blockage, but an overall range of motion. Like I teach just a lateral flexion rotation, kind of a combination of the thoracic spine and lumbar spine. And a lot of that comes from just in utero positioning. So sometimes I will do the more overall range of motion, and sometimes it is getting in more segmentally if I'm not seeing the response from the overall range of motion, whether it's cervical or, like I said, thoracic lumbar. But you can marry the two of them to stretch into a range of motion Yeah. And then sometimes if that doesn't do it, then I'll go back and repalpate and see if there is a particular segment that's blocked that we can free up to get that movement back.
Right. So I think one thing that, to distinguish is the joint blockage definitely does feel different, just so everybody kind of knows that. And that's what people don't want to hear, because it's like relative. It's relative to the age. And so it's going to feel different. You have to know that going into it. And I think as far as the actual manipulation goes, the principles will always stay the same that we teach in MPI. But what are some of the things like the tweaks that you make with the kids? I'm assuming you're not doing a massive body drop on the 5-month-old baby.
On the 5-month-old baby, not
same with the cervical chair,
or a seated scan and a seated,
yeah. But as they get a little bit older, you can do a seated scan on a kid, and I think it's a good way, because they live, once they're larger and sitting in a chair, it certainly applies to them. But just like you would use a different amount of force for a bigger football player or somebody with a lot more muscle than your 80-year-old grandma, like it's the same sort of thing as you work with kids, and you get a feel for the patient. Just the tissue tension under your hands and following that and knowing when you feel more tension, or as you're palpating where you lose that rhythm, like in a seated scan, or it's the same, you can get the same sort of feeling of, oh, my rhythm stopped when I got to this segment. And that's where, there is that tension there.
Well, let's go region by region. Why don't we start with cervical spine? So cervical spine, what are some tips that are different with the pediatric patient from the adult?
Yeah. So one of the things that I've looked at is that when we look at the pediatric spine, we compare the anatomy from newborn to 2-month to 2-year-old to 10-year-old, and even looking at what things have ossified or not. And they aren't fully ossified, especially in the upper cervical spine, until somewhere around 8 years of age. And so there's typically no high velocity, low amplitude thrusting that we do until after that point, when the upper cervical spine is fully ossified. So that's the biggest difference. And as in the cervical spine in an infant, it is all mobilization. It's all pressure on, pressure off. Repeated movement kind of things. And after that point is when we start to use a little bit of high velocity, low amplitude. So it's very, very gentle, I think, is the biggest thing.
And then if you do, it's going to be, do you more like supine, or not necessarily?
It depends on the kid, honestly. Yeah. Like if it's an infant, I'll do supine, like head of table. If it's a kid that's old enough to move around, it could be a seated, like we do the seated palpation where we grab on either side of C1 and we laterally flex and pull across. Like that becomes an adjustment a lot of times, especially if the kid is kind of moving around. Sometimes I can just, while they're playing, I can come in and work on their neck just while they're sitting there. So if they're an older child, more 10 months, a year and a half, like I often end up doing just a seated mobilization.
I think too, before we go on to the further thoughts on that, skill acquisition is a big thing with this pediatric population.
Yeah.
Just like it is with palpation, manipulation, skill acquisition to know how much pressure you need. Honestly, the hard part, it comes with time. Yes. Like it comes with just seeing those patients, but brief guidelines of using your fingertip. It's very hard to make a huge thrust with your fingertip. And so just build in your safety based on what contact you're going to use with those. And so like you're saying there, and to your point of using them while they're playing this stuff, sometimes kids are not cooperating, but they feel really good when their mom is holding them and things like that. And so I think using those positions and using, kind of being more adaptable with this population is really important.
Yeah. Yeah, laying them on the parent's chest and then working with them prone on the parent's chest is one way. Using the pregnancy pillow or even just a contour pillow. As a lot of my students have seen, I like to sit on my table with my legs outstretched and just kind of nestle the baby down against my legs. They're going to be a lot more comfortable in those types of, cradled scenarios than just laying on a cold, flat table. Right. So figuring out where you can get the best cooperation from. Sometimes easier said than done. Some days are better than others. Right. And that's too, like looking at when are you scheduling their appointment? Is it in the middle of their nap time? Well, that's a terrible time to try to treat an infant. Right after they've eaten and had a nap. Yeah. The happy babies. Yeah. Those are the ones you want in your office because oftentimes they're a little easier to work with then.
And they just haven't had a lifetime of having these blockages. So I feel like they're the most responsive patients. Mm-hmm. Usually you can do a couple treatments, have a huge effect just because you haven't had that lifetime of dysfunction that's kind of getting in your way. So thoracic spine.
Well, before we do, can we do a little condition specific? I think a lot of people maybe would ask about acute torticollis or things like that. Where does manipulation fall in this maybe torticolic infant?
Yeah, and again, with going back to the infant and the cervical spine, it's going to look more like a mobilization. And so this is where I might be doing some soft tissue work on the SCM or on whatever tissues I'm finding tight, and then still working that overall range of motion. And then once I've done those things, I will come through and just like segmentally palpate, and like you said, fingertips. And if you're worried about using too much pressure, like using middle finger or ring finger tends to be the most gentle, is ring finger or pinky. But then oftentimes, even though I've worked through the muscles, I'll still find some segment in the cervical spine that is more stuck than another. And so then I'll work, segmentally, like a pressure on, pressure off, laterally flex. You can even do like a little lateral index type contact, but just not with a thrust, and mobilize it, and then recheck your range of motion afterwards, of course. So it does fit that model even on a torticollis type of patient. But
I think a common one that, we all see once we start seeing pediatric patients is ear infections and things like that. Cause we're kind of been told, like, since our profession has begun for 120 years ago, that there's a certain group of patients that are going to respond to an upper cervical manipulation or mobilization. They're out there. I always throw, not to put a functional medicine hat on, but be looking for dairy allergy in those cases also. I would say that, let's just use the pie chart analogy. If we're dealing with ear infection, I think it's like 75 to 80% end up being like in the food sensitivity category. And then there's another group that will respond to us doing work in the cervical spine. But I will say not as big of a group that I would have thought as I was being educated as a student.
Yeah,
and so I think be on the lookout for some of these things, because once you start getting a reputation for treating kids, they'll come in droves to see you.
Yeah.
And then understanding you may have to learn how to look into an ear again. You may have to, like, all these little things you might have forgotten about become important if you are going to be the primary care physician in the pediatric patient, or maybe not the main primary care physician, but if you're the first point of contact, you got to be able to direct them the right way or do the right assessment.
Yeah, I agree. And back to your point too about how quickly they respond. There was a study that AECC did, so born in the college in Bournemouth. They looked at in their pediatric in their pediatric clinic. They looked at all these different markers of why kids were coming to the clinic, and then the treatments that were basic, the type of treatments that we would do, a combination of soft tissue adjusting, whatever we find in the infant population. And, I tell people, like, we don't have a ton of research in peds, but what we do have is positive. And so even in that study, which was pretty short, it was only 2 to 4 weeks, I want to say, they saw a huge reduction in the patient symptoms, whether it's crying or trouble sleeping on their back or, just colicky in general. But in addition, trouble with breastfeeding was another one that the babies improved after being treated. But in addition to that, they saw a huge number of outcomes in terms of the mother, that the mother had higher satisfaction. They had lower rates of postpartum depression. They had less anxiety over what was going on with the baby because the baby was responding better. And they showed a change within just a couple of weeks. So that's another thing is you don't have to treat these kids for a really, really long time if it's just coming in to get them checked. Like our 3-week trial of a care applies to the kids too. They respond quickly if they're going to respond.
Another big one, nocturnal enuresis. So with bedwetting, you will have your group, and there actually is good evidence. There's a couple papers out there that support only the modality of manipulation alone. It can be beneficial for that. That's kind of, I was not surprised, but I mean, it was good to see it. Let's put it that way.
Yeah.
But then back to, like sometimes we see that with also like a dairy sensitivity or like other food stuff that can be related to that.
Yeah. I agree with you. If the child is breastfed and they're having trouble, whether it's digestive or ear infections or colic or just gassy, whatever baby things they're having, dairy is the first thing I'll pull from the mother's diet if they're breastfed. And then typically we might do some allergy testing, or gluten is the next one that I would pull as well. So I totally agree with that. But dairy is a huge one. I think because some of it is the antibodies are coming across in the secretory IgA that's put into the breast milk, and that we like that. That's good. That's how they get that immune function, and the interaction between the mom's immune system and the baby's immune system. Like it makes a huge difference. But then if the mom's got issues with digestion, with allergies, then yes, that actually can be passed into the breast milk.
So funny too. Like sometimes you will work your whole career trying to change this particular person's diet, and they won't do it until they have a baby, and it's not about them anymore.
Right.
And then they will change. Okay. So now we get to like our first like unique anatomical situation. So like with our children, a lot of times we're also not wanting to do like an awkward A to P move with a young child. So then with the pediatric patient, like I'll do like double thumbs from like either a seated or like just holding the baby up. What are some
this
of
is for the thoracic spine?
thoracic spine?
Yeah. Depending on the age, the thumb squeeze, I'll lay them prone and use like the edge of my thumb and the edge of my index finger, and just do like a prone adjustment. If as they get a little bit bigger, think maybe 6 to 8 year old child, like you can lay them prone on the table, and that one's kind of hard because my hands are not small. So if I put my hands on their spine, like I'm covering 3 or 4 different segments. So sometimes I'll do a broader contact like that, knowing that I'm going to get, I don't have a problem with moving a whole segment of a whole section of vertebrae versus just one. If I want something more specific, then I can probably come in and do the thumb and the index contact again.
What's a good age frame that you feel comfortable doing supine adjusting with them in the thoracic spine?
It certainly depends on the size of the child. And even sideline drops, like I feel like I almost have more control with a sideline drop than I do sometimes with a push. So I end up doing a drop on smaller kids, but what I do is I raise up the table, and to kind of limit my force, and I can have speed then too. Like my drop is pretty quick, and that's one of the things when you do start doing high velocity stuff with that little bit older age group. Like sometimes they like to tense up, so you kind of got to wait and be able to sneak in, and I can be really quick with a drop. So I'll do a supine, maybe use an open hand. It just depends on the size of the child and like how much, like somebody that's 3 or 4, probably not, but even by the time they're maybe 8 or 10, depending on their size, I might. So yeah.
Yeah, I think that's the hard part is, in MPI, we teach a lot of supine adjusting, which is great. We love it for the safety aspect and some other things along those lines. But the prone manipulation in these younger age, I think is still, that's where it holds a little bit higher level in my eyes.
Yeah. With an infant, you can even lay them supine and then come in with your fingertips and do like a little bit of an extension mobilization in the thoracic spine. So that's another one, but that doesn't work once they get to even 18 months, then I'm probably switching to that bilateral thumb, or even if they're smaller but big enough that they can stand on my table, I'll have them stand on my table. And I like to have them look back or look up. So, hey, look at what's on my ceiling, because then I'm getting a little bit of extension before I'm doing that thrust. So from the standpoint of like, we're trying to look at, can I put them in that position or can I put them in that motion before I add the force? I think we can get that with a bilateral thumb or with a standing thumb, because you can have them look back or lean back. So, yeah.
I think the lumbar spine too, like the thoracolumbar junction, which in the kids, we see a lot of that joint blockage there. You could, as you say, you could like taper your drop way down.
Yeah.
Or that is the time, like we don't like pushes anymore for the adult patient. We used to teach them back in the day in MPI, but it's just, it can be hard on you. Like it's hard on your shoulder. It's hard but on the child, I mean, you can literally just kind of flick your
You can
wrist
just push. Yeah.
Yeah.
Yeah, and on the smaller babies, like I'll work from, just like a sideline broad hand contact, and you can work from SI joint up into the lumbar spine, into the thoracolumbar spine, just with gentle presses. And they usually really like that one. Yeah. Like they kind of giggle or something. So
well, especially too. I mean, yeah, I know, Brett. I've heard you teach manipulation so much in the last 7 years. Getting your hand higher up into the thoracic spine in adults is very effective with the sideline position, but I feel like it really is in the pediatric patient as well.
Oh, yeah, the thoracolumbar.
So sometimes, even like upper into the mid-thoracic spine with that kind of flick push move that you're talking about. And so I think I think there's a million ways to skin a cat, especially in this instance. And so being creative with what they're able to do, if you have a 5-month child, they should be rolling, they should be on their side. So having them in that position may be a little bit more effective to get a little bit more motion up into those segments. And so then I think just tailoring that to, you pointed to the thoracolumbar junction, usually that's going to mean some sort of insufficiency in the diaphragm. Meaning we're here for a DNS pediatrics course this weekend because usually DNS has the answer as to why they have that joint restriction in the first place. And so would you agree with that usually like some sort of like timing error or maybe just a little bit more higher chest position in those babies is going to correlate more to that mid-thoracic to lower thoracic joint blockage?
Yeah. And oftentimes I am, after I'm adjusting them, I'm putting them in sort of a DNS position to try to facilitate some of that. So yeah.
Absolutely. Why do you think, because it's funny when people already think chiropractic's a little bit weird, but then when you start talking about pediatric chiropractics, then people really get their antenna up. So I guess how do we debunk some of the misconceptions that exist for that? And of course, there's definitely patients that are fearful of bringing their children to chiropractors. So what do you think are some of the ways that have been helpful for you to kind of educate the people around you on what you're doing?
Yeah, I think it's so much of it goes back to just laying out up front. I'm not signing. You don't need to bring your child every single week for the rest of their life. It's not one of those if you're in for a penny, you're in for a pound. Oftentimes it starts with my pregnant patients and talking to them about, hey, you're welcome to bring the baby in. I want to see you about a week to a couple weeks after if you need me. Otherwise, but bring the baby if you're having trouble nursing. Bring the baby if the baby's real fussy. So just setting that up, that expectation to say, I can help things and I can do it pretty quickly. So don't be afraid to bring them in. And then, talking about developmental milestones and I have the posters in my office. And so even talking to parents about bring them in at the next milestone, or if you have questions about where they should be, I can help to screen those things for you. And so that kind of opens the door to just say, I'm not just going to adjust them. I'm concerned about, I want to see their movement as much as I want to see your movement. And it's not just about, can I push on joints and make things pop? But
right.
I think that's the education of it, of just even shifting the focus of what are you bringing them here for? That you're bringing them here to make sure that they're developing, just like you'd take them to the pediatrician to see that they're developing the right way.
And I think you might not need to do anything. Just exactly. There's these DNS checkups that we do on the kids. If everything's going the way that we want, then we don't necessarily have to have an intervention or a treatment. So if you're honest with yourself and you're joint playing the child and there's nothing there, you don't have to make that happen. You can't make something be there that's not there. So
it's so valuable though for parents too, to be able to bring them in and us do an assessment on them and say, your child looks great. They're developing exactly the way they're supposed to be. Look for, this is what they'll be doing next, but they're not ready for it yet. Don't rush it. And I think that reassurance of they're exactly where they're supposed to be. Stop hearing, your friends say, but mine walked at 10 months.
Right.
The mommy competition or whatever it is.
Yeah. Oh yeah.
Well, I think it's too, if you have any inkling of doing functional medicine or you have a nutrition background and things like that, you can catch so many things early on too. Things like cradle cap and diaper rashes. And, oh, by the way, they've had their third ear infection. That's where you can have an influence on these people's lives, and especially on the child's life early on, because a lot of times they, like you said, they go to the pediatrician for their child checkup. Well, they're in the 21st percentile, so you need to add this. And a lot of times there's not a lot of nutritional backing behind those things. And so being able to be the positive influence and say, yes, they're in the 21st percentile. By the way, there's a lot of error involved with that, but here's some ideas that we could do to make sure that they're getting the nutrition they need. And that, I think, gets a lot of buy-in as well. Oh, I never thought of that. Or, hey, I see how you're holding them, just to make sure that their hips develop properly so that they don't have some of the issues that you and I have. Then this would be a better way of holding them, or this would be a better idea for handling her. And then that usually opens the question to, hey, yeah, I got gifted this. Is this good for my baby or not? And then we can kind of start to have a little bit more influence in there and make sure that the childs are hitting those milestones, but then not preventing them from reaching the next one.
Yeah.
And I think it doesn't need to be a barrier. I feel like when you start exuding the confidence and certainty that you're talking about, you really do not need to even like advertise the pediatric. They'll bring them to you. Like they really will. Once you start getting your reputation in that world. Yeah.
And I think with some of our post or prepartum or what's the right, not prepartum, but what's the right word for it?
I mean,
perinatal or whatever, the prepartum, whatever. During the pregnancy, a lot of the times that we're doing these, pre-pregnancy exercise programs and checking on with the pregnant patients, majority of the time we're using developmental positions. And so I think that's also a good way to kind of, just subtly hint that, oh, by the way, your baby, when it's at this age, is going to be using this position. So like, this is something that we'll check on, or, like I always just say at 6 weeks postpartum, come see me, bring the baby. I'll look at it for free. Don't have to put an appointment. Just let me check it out. And if I feel like there's something that needs to be intervened, then we'll discuss what needs to happen from there. But at least let me just do a little neurologic exam, make sure that they're doing well in those first 6 weeks, and then we can kind of discuss what needs to happen next.
Because really you have, not that it's about this, but you have 2 years of intervention because you have, once we become pregnant, I spent early part of my career solely working with the pregnancy patient in a hospital system in St. Louis. And I learned a lot about like that population. So you have, they can't be taking pharmaceuticals, so they need to be minimizing pharmaceutical usage. So then you're following up with them. We follow up with them once a month, typically, no matter what. And then you have the baby. Well, then you have the whole postpartum phase, which the research that we exposed 20 years ago was these females that are having back pain, just because you have the baby doesn't mean that you no longer have back pain.
Right.
And that is clear in the research that isn't a guarantee. So then you have that postpartum phase, which let's call it another, I don't know, we'll say year. Mm-hmm. So like you have a 2-year window there. That's why this niche is becoming so attractive to, usually it ends up being our female practitioners, but you have, pregnancy, postpartum treatment. And then of course you have the pediatric treatment, and that right there, Bill, I mean, that's enough patients to go around.
Yeah. Yeah. And I've made a lot of connections with doulas and midwives in my area, and those have been the ones that, like, if they need, if they need a referral, they like referring to me, and I like those particular patients too, because you generally get people that are fairly health minded, more like minded in terms of natural health and things like that. So they've fit really well with, in my practice, and yeah,
absolutely. Well, let's get back on track and kind of, we talked about the thoracolumbar junction, lumbar spine, pelvis can probably be lumped into one here. What are some of your biggest tips for, palpating the pelvis? Number one, what are the implications of maybe stiffness in the pelvis as we develop and things like that?
Yeah, it's pretty similar. I mean, it's part of it is trying to figure out how do you palpate an SI joint, and you can wrap your whole hand around their pelvis. So instead of, using your knees and using your hand, it's literally using your thumb on the ASIS and then your fingers across the SI joint. And that can become your little palpation. Certainly anytime I've got my hands on the pelvis, I'm checking the hips, I'm checking Ortolani's and Barlow's maneuver just to make sure I'm not feeling any clunks. And the pediatricians are doing that at every visit, but at the same time, like, it's good. We have good hands, and oftentimes we feel that pretty well. So, just checking that and knowing that if you feel something that, either refer them back to their pediatrician or order, an ultrasound. The ultrasound has been much more sensitive than X-ray because there's so much cartilage left in the body at that point. So
X-ray too.
And not wanting to do X-ray. Yeah. So certainly that palpation we're used to, of just checking the SI joint, but then also looking at the pelvis as a ring and challenging the ring of the pelvis in one direction and challenging the ring of the pelvis in a different direction. And again, if we think back to like distortion of in utero, like where they breach and stuck, with one hip down in the mom's pelvis, well, that's going to create some distortion in the baby's pelvis too. So same thing, it might be just a tension hold. But it's not something we really do in adults because it's so bony, but it is something that you can feel a difference sometimes in that, I don't know what you want to call it, clockwise and counterclockwise shift of the pelvis. So
my Logan showing, but like
I was getting ready to say that. Yeah.
For those of you who, did go to Logan, we learned a lot about Logan Basic, of course, and we don't use it really for the adult patient, not because it's not effective, just because it's a little bit awkward. But in the pediatric patient, I feel like, you could teach people how to do this in 2 hours, like people who are trained with their hands. And so what I do is I grab the whole pelvis and I have my thumb on a sacrotuberous ligament, and it's almost like you're steering, and you can actually palpate the tension in the sacrotuberous ligament with your thumb. Yeah. So it's no different than a joint. If you've done it 10 times, then you kind of become the expert at it. And then you can just like kind of like compare. And Hubie Logan, who obviously the school's named after, I mean, he talked extensively about the pediatric patient and how like they're basically made for, you know, that treatment for a lot of different reasons. So I think like because of how small the pelvis is that age, you really are in a great spot. And again, we've modified it. We don't do it exactly the way that it's probably being taught, but the principles they're very good. Mm-hmm. Yeah.
Yeah.
So, I mean, the sacrotuberous ligament in general, I mean,
connected to everything.
Yeah. If you just follow mechanoreceptors in general, it's going to be up on your list as far as the amount of mechanoreceptors in there. So, and then what about just checking for hip dysplasia? Like what are some of the most common signs and symptoms? What are you really looking for when you are doing those, the orthopedic testing or palpating through there?
Yeah. So it's bringing the knees bringing the hips up to 90 degrees, a little bit of adduction. I do one at a time. So then pressing posterior, like we would do with a posterior shear test, and you're feeling for a clunk. Mm-hmm. And then the opposite is once you've done that, you take your fingers on the outside of the hip, and it's almost like you're pushing the head of the femur back into the socket. And again, if you feel a clunk or if you feel that slipping of the head, that tells you that there's some lack of that, the acetabular development. So I think like we've talked about this weekend, the excessive abduction, where even if the infant, like newborn, is laying on their stomach, like are their legs splayed out? They shouldn't be splayed out. They should be able to have them tucked up underneath them and kind of keep them there. So that can be a tone issue. It can be a acetabular development issue. But though I'm more looking at the palpation of it, and in my certainly there's the observation, but in terms of the assessment, it is that posterior shear and then pushing the head of the femur back into socket and looking for a clunk.
And then once you get beyond 1 year, the most common reason for a unexplained limping child is hip dysplasia or slip capital epiphysis. So like the first thing on your differential diagnosis, because you'll hear this, I mean, they'll say like, I don't know why, but so-and-so now is like limping now. So number one on your differential diagnosis is to make sure that we haven't like exposed some kind of like a structural hip problem. And then you can start working backwards from there. Cause of course there's a bunch of different reasons why, but the limping child after the age of 1, look out for, and then look for, well, some big ones too are like gross structural leg length inequality at a young age can be one of the causes of like a snapping hip or a limping child or something like that. So always just but kind of pay attention to that and then work through your differential diagnosis.
It's a good. I mean, that's a clinical pro you gave me early on. Is whenever you see a limping child, red lights start going on just in general. And, obviously there's other explanations for it, but do your due diligence. And the ultrasound for the hip, that's I love that. I love that idea. What else, as far as within the spine of a pediatric patient, Erika, that you find is maybe some clinical pearls or some things that you've noticed, or maybe just a little bit more encouragement for the people that are getting into this, or, maybe struggling a little bit when they are palpating and then adjusting?
Yeah, I think what we said before too is just the hands-on, like how do you get your hands on kids? And so, no, don't rip any off the street. Find a friend, but find a friend with some kids and get on the floor and play with them. Offer to hold them for a minute. Offer to have them come sit on your lap. Palpate their spine very gently, and just figuring out what a child's makeup feels like. I think that's such a huge thing. Is just like we have to palpate so many adults to know what's normal and what's abnormal. I know that you don't get a ton of information on how to treat pediatrics in school, but knowing that the motion palpation applies still, knowing that the forces that you use are just like you would turn them down for an adult, you turn them down for the child, and then working from there. I mean, that's probably the best insight I have.
Right.
And oftentimes, like when you first start with this, you're going to feel like you're not doing anything, and you're going to find that even that little bit that you did can oftentimes make a huge difference, because the forces that we need in children are so low. You can start to see differences pretty quickly. So knowing that you don't have to do so much is, I think, a good way to start, and just start easier, make it a positive outcome or positive experience for the patient. And then, know that hopefully they'll come back and see you again, and you'll be able to build on that.
And sometimes even if you're not on the primary reason why, that doesn't mean that we still can't offer a benefit. Like if you look at the Bronford report, was like kind of like a scoping review of what manipulation is good for. And on the pediatric patient, one that really kind of jumped off the page for me was basically that the evidence is showing we don't do well with asthma, which I think in the back of my mind, I'm like, well, we might be not getting after the primary reason, back to dairy, but
I was going to say that's another nutritional conversation.
But you could, you can have, let's just keep going with a casein problem. So if you have like a casein allergy or sensitivity, that can be creating tension, tone, and trigger points in the soft tissue, which is leading to joint blockage. And I mean, that is Irvin Core's viscerosomatic reflex, basically. So just because you may not be, because I saw that, I'm like, what are you talking about? Like these asthmatic patients, they become, I hate to use this term addicted, but they get addicted to us because we give them relief to be able to, you know what I'm saying? Yeah. So like you may be missing what the actual cause is, but it doesn't mean that manual therapy should be not part of the program, probably.
Yeah. No, I agree. I think going back to that study of from AECC, that a lot of times I tell patients, well, I don't have a research article that says that absolutely I can help with this, but it's worth a trial of care. Mm-hmm. And let's do 2 to 3 weeks at a couple times a week and see where we get. Because if we see some positive outcomes, well, good. Maybe that opens up other opportunities for them. So yeah, I'm willing to try on a lot of different things.
Well, and I mean,
because it's short term, we're inexpensive, we're easy to access, and the side effects are a baby who sleeps better and probably has a good bowel movement. Right. So I mean,
well, and BJ Palmer, not to go all philosophical, he actually said like the wonderful thing about the pediatric patient is the power of suggestion or placebo is kind of off the table. Sure. So like any benefit you're really getting is pretty pure, right. So I think that also, means we should be doing a better job with the pediatric patient, probably. Absolutely. Because we're, like you said, we're not expensive, and there's no harmful effects with what we're doing.
Right. Yeah. There's safety built into it. Yeah. And I think we've mentioned casein a lot, dairy. It's a very easy lab test too. If you're having a hard time convincing the parents, I mean, you could send the child a LabCorp request and get an IgG panel really quickly to basically determine it. And that's it's pretty cut and dry.
Numbers. And like what I tell the functional medicine patients, the fix to your problem is simple, but it's not easy. Mm-hmm. And so, but I mean, I think it's all how it's sold to them, and so that's all like the soft skills of being a good physician. Is there anything that our listeners or viewers would need to outfit their offices to make it more attractable to the people? I mean, you see like horse and dog tables, see all kinds of crazy stuff. I don't see myself getting that, but like, I don't know, the obvious ones like stuffed animals and. Yeah,
I have a bucket of toys, and if they go in a kid's mouth and they get wiped down, so things like that. And then just simple things like, making sure that they can't pull things off of tables that are going to be hurt them, making sure you've got plug covers on the plugs on the walls. Depending on how you're approaching it, like a lot of times I have some towels, some bigger towels that I can throw down on the floor, or a blanket that we can throw down on the floor so that we can, so many times my first appointment is me, if it's an older child that's moving around, it's me sitting on the floor with the child, watching them move around, handing toys back and forth, watching them pull up, watching them crawl, and then just getting them, and that helps them get comfortable with you. If I can avoid, being the doctor looming over them or wearing a white coat and putting them flat on their back on the table, like anytime that I can come down to the floor and work with them, I think that's a good measure. So that might take a little bit of, adjusting what your office space looks like. Right.
Or having an area set up that you could
that
transition
you could
to
do that. Yeah. I don't have any special children's tables. I just use my big mat table, or they're in my hands anyway. So yeah.
I think the pregnancy pillows are a great investment. I think they're so versatile, like you said, using them for the pediatric patient, but then also if you have pregnancy, it's an amazing. I have patients that come to me just so that they can lay flat. You know,
it's an arms race.
Yeah.
For,
Oh my gosh,
who's got the pregnancy?
Yeah, it is, and so I think that that's a no-brainer investment for a couple $100 like that. That's a no-brainer for me. One more topic, if we could. The number one question I get right now, and it's a really hot topic, is lip and tongue ties. Do you have any opinions on that? Do you want to go there?
Yeah, it is not my area of specialty. I do look at them, and there's been a couple other chiropractors in my area that have really gone down that route, and I tend to refer to them because I know they know a lot more than I do.
Yeah.
Some of it though I will look at like the shape of the tongue when they're crying or when they're opening their mouth. I'll look at if there's if they can get past the teeth, if they can get to the lip, what the shape of the tongue is when they're crying, or if it's retracted. And then I'll go, I think you should get this checked out. But I do not myself treat it, other than like talking about just there's some oral toys that like when they're teething and things that they get back to the molars, which helps to facilitate like the lateral movement of the tongue. Like I'll talk about some of those things with my patients, but I don't specifically treat lip and tongue ties.
Well,
I'll screen for them
time right now because it's one of those unique situations where it's almost like the more holistic practitioners are wanting the more invasive treatment. And you just, if you believe in the fact that we're kind of all evolving at the rate that we should be evolving, to think that 90% of our patient population needs one of these procedures, I think it's probably crazy. But then is there like anything going to be a subgroup that's going to benefit from it?
Yeah.
And, podcast teaser, we might be having one of the experts in the world coming up. Alert.
Right.
But,
and I think we're in a little bit of a unique situation too. We have a great pediatric dentistry in Troy, and then one in O'Fallon that specializes in that, and they have options, and they're very holistic in their treatment. They give options. They check it out and say, yeah, I think it is an issue. And so usually what I'll do, just speaking for myself, is if I do suspect it's an issue, I say, hey, go to them, just get their opinion, and then come back to me, and then we can kind of discuss what the options might look like, or what the long-term effects could be and things like that. And so again, like these are the questions that are going to come up because the pediatricians really don't have an answer for it. They don't even know what it is. They think it's ridiculous. But again, I think that there is a subgroup that it does matter if they're having issues with feeding, if they're having issues with breastfeeding, like it could be something that we talk about, which again, we will have a more deep dive into this with a future podcast, but I'm always interested in people's opinions.
Yeah, I usually refer back to the lactation consultants for that. I have a couple of really good IBCLC certified lactation consultants that know how to screen those things and work with the latch and the positioning first to see if that can correct the feeding issues. And then if we're still seeing problems, if we're still seeing shape differences with the tongue, then we might refer to more of a specialist with that. So yeah.
Love it. That was great, guys. Great conversation. I think pediatrics is just like pediatrics with pregnancy. I mean, like it is such an underserved population, especially from our perspective as far as, more holistic manual therapists. And I think it can be a little bit scary at first, but once you start, it's so much fun. Like, I have this weird practice where I treat a ton of high school athletes, but then I have a bunch of pregnancy, pediatrics, and postpartum. And some people may say, oh, well, you're a male, so it's hard to do that. And it really isn't. Mm-hmm. Like you just get over the weirdness. They don't care. No. I mean, they just want relief. They want their baby to sleep through the night, and they don't care who gets them there. And so just be open-minded and start getting good with your hands. I think pattern recognition is so important with this population. Getting your hands on, like you said, like I was lucky my sister has 3 kids, and that's what I did. Whenever I was around them, we worked on them. Like that was just like my avenue to start getting better at it. And then, just kind of snowballs from that.
Or like in the DNS Pete seminars, everybody brings a doll. So, I mean, you could start practicing on a doll, and I would just kind of piggyback what you said. So, the one thing that we learn, no matter what seminar you go to, whatever the technique is the people that are doing a good job in this world, it all comes back to affrontation. Like we've heard Marcella talk about this for 3 days. We talk about it at MPI and things like that. So manipulation is a non-nociception sensory input into the spine, right? So what we're doing is basically creating a better window for affrontation. So like, don't underestimate the chiropractor's ability or physical therapist's ability to do this for the pediatric patient, and don't be afraid to do it.
That's right.
Yeah.
Yeah, I think one more thing popped in my head. You made a great comment on, we had 2 patients yesterday, and they were not extremely cooperative. They were a little bit loud and yelling and crying and things like that. And you made the point of, it's great for people to see this because this is reality.
Yeah.
It's not within a baby's schedule to show up to some random person's office and get touched, and so I think just being okay with some of that. They're not going to be perfect and happy every single time, and being okay with, changing things day to day and adaptability, I think is a really good point too.
Yeah. Yeah.
Once you have kids, you're so used to it.
Right? Like they're not dying.
Right.
It's okay.
It's going to be fine.
I think the education to the parent too, of saying like, okay, this isn't in their agenda. They're probably not going to like what I'm doing, but and I'll grab their arm and be like, this is how much pressure I'm using. I'm not using enough force that's going to hurt them. Just to reassure the parent, and talk to them. I sing to them sometimes when I'm treating them, and I like the idea of telling them what we're doing. So I always think too that even though they're not verbal, talk to them as if they can understand you. Mm-hmm. Say, this is what we're going to do now. Okay. We have to avoid the okay, because oftentimes if they can verbalize, they'll be like, no, but telling them what you're going to do before you could do it, just as out of respect for them as an individual, as a human being. And I do think that they can understand our intent and our tone and things like that. And I think that helps a lot. Older kids, I've even said, if they're new to my office and they haven't seen me treat the parent, sometimes I'll say, well, do you want to see how I'm going to give mommy a back rub? Do you want to see how I give her a back rub? So then it kind of demystifies a little bit. And then it's, okay, now come and lay on your mom's chest. I'm going to give you a back rub now. And I just term it as a back rub because that's something that they can understand, and it's language that they have some framework, as opposed to like, let me adjust you now. What does that mean to them?
Right.
So
Marcella made the point this weekend too with one of our patients of like being upbeat, like, okay, we're gonna exercise today, and then at the end you say, great job, we finished. It was amazing. You're doing amazing, things like that. And I think your intention of positivity, it matters. We're getting a little philosophical, but I think it does matter. It doesn't matter if it's a pediatric or an adult patient, your intention matters. And so if you're a little bit unweary or, not 100% confident, even though you aren't confident, you got to exude the confidence, and you got to tell them and show them that it's going to be okay and they did a good job.
Yeah.
So.
I think I try to avoid too saying, you're okay. Well, the baby's crying. The baby's trying to tell you in their world it's not okay.
Right.
So you're doing good work. Oh, this is so good for you.
Mm-hmm.
Look at like she said, look at how strong you are. I'm thinking of her words right now. I have other things I've said too, but I just the positive language of acknowledging like, oh, I know this is tough work. You're doing a good job. I think makes a big difference too.
Absolutely. Well, I highly, 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 highly encourage you to seek out Erika, especially when she's teaching pregnancy and pediatrics for the Motion Palpation Institute. It's a great course, especially again, like if maybe you're not all into DNS and manual therapy, but you just love manipulation. Like this is a course that's going to teach you a ton about manipulation and probably get you a little bit more excited about that population. And again, we've talked about it extensively, but this is an underserved population that needs our help, and you can be that person. So
the next one is Daytona Beach, Florida, the weekend before Thanksgiving. So
get the beach.
Come check it out in Florida in November. So
it can get a little crazy down in Daytona.
I love it. Well, Erika, thank you for sitting down with us not once but twice this weekend. Thank you for continuing to learn. Thank you for teaching us all, and we're super excited. Oh, by the way, you will be at the MPI Adjustathon.
I will be at the Adjustathon.
The Super Bowl of Adjusting seminars. Make sure you're there at motionpalpation.org. Otherwise, guys, good luck with patients, and we'll see you next time. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.